Hi, welcome to Virtua Health's Real Talk Women's Health Chat. My name is Nicole Mahalik from 92.5 XTU, and I'm so excited to be here. This is one of my favorite things to do. It's such an incredible event that we do that is going to inform and educate and just make you feel so much better about yourself. Talk about three amazing, badass women that are about to change your life. Seriously. Okay. I'm pleased to introduce three experts for tonight's session: Virtua OBGYN, Dr. Rachel Kramer, Nermeen Lazarus, lead clinician for Exuberan by Virtua, another incredible doctor, and Andrea Martin, an APN from Virtua's Sexual Wellness and Pelvic Medicine practice. All right, so Dr. Kramer is the medical director of women's health and services at Virtua and has over 25 years of experience in obstetrics and gynecology. She is a triathlete. I mean, this is why doctors always blow my mind, because they always do so much more than just save lives. It's like, oh, I do triathlons too. And she co-wrote a book on exercising and pregnancy and going beyond labor and delivery. Incredible. Dr. Lazarus is a board-certified family physician in practice for 25 years, med school NYCOM/NYIT internship residency at Good Samaritan Hospital in West Islip, New York. She has a passion for women's health and has been primarily focused on this for 10 years. Previously a women's primary care physician, and now is the lead physician at Exuberan by Virtua. Dr. Lazarus is married and has 3 grown children, and her best times are spent on the tennis court and with family and friends. We got to ask her if she likes pickleball too. A lot of tennis people are like, no pickleball. We could do a whole seminar in tennis versus pickleball. I love it. That's so great. Andrea Martin has been practicing as a women's health nurse practitioner for 10 years. She received her master's in nursing science from Rutgers University and her doctorate from Misericordia University. She enjoys focusing her practice on helping women with chronic pelvic pain, sexual dysfunction, and menopause. Andrea is obsessed with adopting animals and spoiling them rotten. After work, you can find her pushing her elderly dog in her stroller through the streets of Philly, or cross-stitching nerdy medical humor designs. Fun. I will look for you on the streets because I live in the city too. So welcome everyone. Thank you so much. I am so honored to be able to hear your expertise this evening, and obviously everyone that signed up and is going to learn so much. So obviously this is going to be a lively discussion, and it's centered around menopause. And we've learned over the last couple of years that there's just not enough information. You know, it's almost like it's this quiet thing that no one talks about, but billions of women go through it. You can't avoid it. And it's time for women to feel comfortable talking about it and to feel better about themselves. We have so many questions that the attendees have already sent ahead in the session, like, why does your hair grow in places that it hasn't before? Although I will say my Uncle Tony always talks about his joke, why do I lose head on my hair, but it grows in my ears? And why do my energy levels vary so much from week to week? So let's get started. Dr. Kramer, what is the difference between perimenopause and menopause?
Well, menopause is a clinical diagnosis, and it means just not having had your period for a year. The average age in this country is 51 and a half. Perimenopause can happen 2 to 8 years earlier than that. So women can experience perimenopause in their 40s and in their 30s as well. Perimenopause and menopause, in perimenopause, you're still ovulating, just not as much and not as strong as you did before. So your estrogen levels in perimenopause are fluctuating, and sometimes that can cause issues. Sometimes you can have abnormal bleeding because you're not making enough progesterone when you don't ovulate as well. And you can have mood changes, you can have hot flushes, and in menopause, you can have all those things, but no bleeding. Bleeding in menopause is always abnormal, but it needs to be worked up immediately. But But menopause is when your ovaries are not functioning anymore in the sense that they're just not making the estrogen. You're not ovulating, and that's really the difference. And it's a long journey. It's really impossible to know exactly when you'll become menopausal. Some of it's genetic. You tend to do what your mother or an older sister did. Things that can change that would be smoking. Cigarettes really kill ovaries, so women who smoke tend to go through menopause a lot earlier. Otherwise, you're genetically destined to hit menopause at a certain age. That's determined from the time you're a fetus. You have a certain amount of eggs, and that's sort of how it goes. So that's the difference. And more than 60% of women now are surviving into their 80s. That's more than 40% of a woman's life spent in menopause, which is a large amount of time. So I think it's important that when you go to talk to your physician or your provider, a healthcare provider, that they take the time to talk about that with you and not brush you off. I hear a lot of our patients will say, I was brushed off. They didn't want to, my provider didn't want to hear about it. Just told me to, meditate and other things. And, these are real changes that women go through, and it can affect your everyday life. It doesn't affect every woman, and certainly not every woman the same, but it certainly affects a lot of women.
That's such a crazy statistic that there's a chance that you could be in menopause almost as long or longer than not in menopause. It's like, I mean, us women really go through hell, don't we? It's like, and think about how this is why I think these discussions are so incredibly important, because you think about how, for so long, and even like, I think about myself where like you weren't allowed to talk about having your period, if you needed to use a pad or a tampon, you had to hide it. Men would be like, oh, you in a bad mood because you're your period? Yeah, Chad, I have blood gushing out of my vagina. Yeah, how would you like it? You know what I mean? Like, thank God we're finally talking about this. All right, so as a gynecologist, I'm sure you get these questions from your patients every day, but how do you know when you're starting perimenopause, and when should women expect that? I think you just kind of answered that already, where you just said it's the age,
Yeah, and it could be in your late 30s. And if you're going to go through menopause at 45, 2 to 8 years prior to that, you may start to have symptoms. So that could be in your 30s. So, and there are women who still menstruate up into 58. I went later than 52. A lot of women do. Some women go earlier. Most people, though, 40 menopause, not having a period, it's 40 or above.
Yeah. Dr. Lazarus, is there anything you want to add in regards symptoms, or anything that you feel that women should be aware of in regards to perimenopause and menopause? And Andrea, please obviously jump in too if there's anything you would like to add to that before we move on.
Oh my God, there's so many symptoms. There's so many symptoms that women just, before we talked about it, thought it was because of their life situation or their stress level. But I'm telling you, I mean, between the hot flashes and night sweats are the typical symptoms for menopause, but there's brain fog, forgetting why you walked into a room, or word retrieval, feeling like your, anxiety is through the roof, dry, itchy skin that, for no reason, decreased libido. I mean, you'd rather do anything else than have sex. You don't want to, you can't stand your husband or your kids. I mean, all those mood changes and things around menopause, and it's all because of hormonal shifts. It's things
Is that menopause, or are they just being jerks?
A little bit of both.
How do you decipher what's menopause and
both.
being jerks?
Right. We used to tolerate it before, now no more.
Yeah.
Yeah. And I would add too, because I tend to see things more from like the sexual side of things, that physically, very, very common, women develop what's called genitourinary syndrome of menopause. Rolls right off the tongue, beautiful name, but basically it means you've got all these changes that happen to the vaginal tissue, the vulva, even the bladder, and it can cause, we always hear vaginal dryness. It's more than just dryness. It can be outright pain. It can be an increase in urinary tract infections, pain with sex. And this is something that gets progressively worse over time if it's not treated, but it's like super, super easy to treat. I also have women, saying that like my orgasm quality is different. It used to be easy to orgasm, it used to be more powerful, and now it's kind of like meh. So definitely notice some of those changes.
This is a really,
yeah, I mean there are estrogen receptors everywhere in the body, just as was said, in the bladder, in the skin, in the hair, everywhere in the joints. So all of that is affected when you're menopausal and your estrogen is depleted. It really is a life.
and you brought up about, it's not just vaginal dryness, there could be other factors. And I think it's also important too, because a lot of women, and especially women now who are 50 above, again, we're starting to now, and Virtua did a really great seminar last year just about pelvic health and sexual wellness, and just about how like women, you still should be enjoying sex. Like it still should feel good. And I think a lot of women think, oh, I'm over 50. Oh, I'm through menopause. Oh, this is just how it is. And again, great why we're doing this, because it's like, no, you're not supposed to feel miserable. Like you're supposed to actually enjoy it. And so I think it's a really good thing that we're actually, talking about that. It's not just the brain fog and the night sweats, that it really affects your sexual health and so many other factors of it too.
And it's important that you discuss this with your provider sooner rather than later, because the longer it goes on, the longer you're without estrogen in the vagina, the harder it is to get you back where you were. The vagina is a muscle and you have to use it or you lose it. So it's really important, you treat the symptoms that you have. That dry vagina, or painful intercourse is something you have to speak about with your provider.
So a lot of people in the Q&A that I'm seeing, and there's so many questions. This is a hot topic, menopause, but a lot of people are saying joint pain and joint stiffness. Can you speak a little bit about what causes that and why that happens so much more intense in menopause?
So let me tell you something. Snap, crackle, pop is not just for a cereal. Literally, every morning getting out of bed, everything hurts. Frozen shoulder is something that happens around menopause, bursitis, crazy things, and for no reason. It's not like be exercised and caused anything. It's just the hormonal shifts and like Dr. Kramer just said, estrogen receptors all over your body, and joints are one of those places. So there doesn't have to be any underlying arthritis or underlying injury. Menopausal hormonal changes can affect those joints.
Yeah, that is so wild that I don't think people, like you said, I don't think people realize like, oh, did I tweak my shoulder? Why am I feeling this way? And there's so many things like we talked about, just the brain fog, the joint pain, the mood swings, the dry itchy skin. I bet you a lot of people just thought, oh, did I develop eczema, or like, am I allergic to something, and not realizing that it could be menopause.
Right. Yeah. I remember being on vacation and being in a pool at a hotel, and they have so much chlorine in those pools. It was in New York City and it was an indoor pool, and I remember coming out and being so itchy, from that, and that never happened before. So there are definitely things that happen that you just don't know, haven't noticed before, that really it really does help to treat. And when you treat, you either moisturize or use estrogen. It really does help take away those symptoms.
So let's talk about what symptoms are permanent after menopause too. Like, how long do these symptoms last? Do they stay? And then what do you do about them?
Well, so the symptoms, they last, they're there, you're menopausal to the end, that's for sure. So, if you're, it's good to keep your vagina well estrogenized. I think that's important forever. That's something that needs to be done forever. I think with hot flushes, we don't know, as you said in the beginning, the science is just really not there yet. They really only started doing research on women, in the 2000s.
Yes, I literally saw
Yeah.
probably a TikTok about this, to be honest. I was gonna say read an article, but I'm probably saw it on a TikTok if I'm being honest. And I was like, is this real? And then I Googled it and I was like, oh, so many medical studies were like on just regular white men.
Right.
And I'm like, how I was just like, I was surprised, but not surprised. And I was like, this is why technology is so important, and even social media in a lot of ways, because it really gives people a voice to talk about what's going on, and that people feel less alone. And that's why doing these seminars, like the amount of questions that are coming in from women are amazing. So I could imagine you as medical professionals feeling frustrated sometimes because you're like, wow, this research is, we only have a little bit.
Yeah. I mean, hot flushes, they don't know. They used to say, oh, they last just a couple of years. Turns out that's not true. Certainly not for everybody. Some women, it's a couple of years. Some women, it can be decades.
Mm.
So, we don't know. We don't know why. They're trying to figure out, does it correlate with heart health? Does it not? We just don't know at this point. There's a lot we don't know.
But I think, the most important thing is that, these symptoms may last a year or 2 or 10, but the most important thing is now that we're talking about it and there's treatments for it, now that, women are more aware, they're actually seeking treatment and they're asking for help, which is something that our mothers didn't do, 20, 30 years ago.
Mhm.
So that's huge.
I used to have a woman I worked with, and she'd always call it a personal summer. Hold
Right.
on a minute, having a personal summer. I was like, that's good. Everybody was Joyce. Good. That's like good, Joyce. So let's talk about, before we get into hormone replacement therapy, because obviously we really need to dive into that. But are there any like natural solutions that women, let's say they're going through perimenopause or in the early stages, it's not really intense, so they want to try something natural before they try hormones. Is there anything that they could look into, or is that a waste of time?
I mean, you should always try. There's things you can always try things. There's things like black cohosh or remifemin that are soy products, that help some women. Certainly, avoiding triggers can help women. So there are some things like that. Really and truly, estrogen is the best, replacement for almost everybody.
Yeah. Andrea, have you
I would argue.
Yeah, go ahead. I
I was gonna say, I would argue that hormone therapy in general is kind of natural in a way. I mean, if you think about it, especially when you're taking, I'm sure we'll talk about the term bioidentical, but bioidentical progesterone and estradiol, these are all hormones that your body up to a certain point was pumping out in great amounts, and now all of a sudden we're at this kind of deficit. So it's kind of tough because in some ways I think if people have, an issue with their thyroid, they just take thyroid medication. It's not so much of this like, what workaround can I find? And, not that there's anything wrong with it, but I just hate for people when they almost feel like they can't just go right to the stuff that works. Because we don't have to suffer if we don't want to.
Mhm. Yes. The suffer is such a
Amen.
good
Amen,
word.
sister.
Yes.
That's
Suffer is such a good word, because I do think in a weird way that like some women are ingrained to think you have to suffer, right? Your moms are going, menopause is hell. You just have to deal with it. And it's like, well, no, if there's new technology and new medicine and new ways that like we can have relief, like you shouldn't have to suffer, right? Like there's this weird thing where sometimes women have this thing where they feel like they have to suffer. And I just think that that's ridiculous. So it's good that we're saying like, no, you don't have to suffer.
Yeah.
All
I
right.
plan on having no idea that I'm going through menopause. I am going to medicate myself and I'm going to sail right through and it's going to be great.
Yeah. Yeah. It's like, it's okay if something's easy. And I'm curious, I don't know enough about how women are in other countries, but there is something in just America in general. It's like, pull yourself up from your bootstraps type of mentality. And it's like, it's so like, we shouldn't have to always struggle. You know what I mean? If you have the ability to not struggle, that's okay. It's okay to have something be easy and not be miserable. And sometimes, especially for women, it's like, you got to take care of your kids. You got to put everybody else first, and they never think of themselves first. And so I'm glad, we're really honing this in. All right. So let's talk about hormone therapy. Bioidentical hormones. People are throwing it in. We're talking about the pellets and alternatives and all that kind of stuff. So we're going to break it down as much as we can. So bioidentical hormone therapy, BHRT, uses plant-based hormones that mimic the ones your body makes. And so it basically kind of explain if people are confused about what that is.
So bioidentical hormones are made of plant-based medications, and they mimic what your body made prior to menopause. They're really the reason they're called bioidentical is because they're identical to what your body made. They only replace what's missing. They're not adding to anything, and they're more individualized and personalized as far as the dose. They're based on your symptoms, your body, your BMI, your blood test results. So they're very, very personalized to you specifically, as opposed to traditional hormones. The traditional hormones are made of the same things. They're also bioidentical, but there's one or two doses, and that's really it. So, good luck and hope you don't have any problems. Whereas in the bioidentical world, it's called personalized medicine, which is really the wave of the future.
So-
the one thing, oh, go ahead.
No, you go ahead.
The one thing that the bioidenticals offer that traditional hormones really don't is the testosterone, and that is a godsend as far as energy level and libido and brain fog and the muscle aches and just overall function. Depression, anxiety, fatigue, all of those symptoms are something that bioidentical hormones have that really the traditional stuff does not. And not only that, the traditional hormones can actually worsen libido, believe it or not. So it's kind of a tough situation when it comes to traditional therapies, where bioidentical women.
Yeah, and I think one thing to keep in mind too is that, with the Women's Health Initiative, they only looked at Provera. Provera is not a bioidentical hormone. It is not that sort of a hormone, and that was the only progesterone studied, and but prometrium or compounded progesterones, have not been found to increase any risk of breast cancer. Estrogens certainly have not. Actually, in that Women's Health Initiative, what they found out was that estrogen alone actually decreased the risk, probably because most of those women, were getting their mammogram. We make sure women get their mammogram every year when they're on the bioidentical hormone, because estrogen will grow cancer, but it doesn't start it. It doesn't increase the risk. The bioidentical, the plant-derived hormones of progesterone are not felt to do that in that way for many decades. When I was at Yale and studying hormone replacement therapy back in the early 90s, that's what we all talked about, that Provera was the problem. And then that is what was shown later in that Women's Health Initiative. So it is really important to use the plant-derived hormones. They're better. And that's what Europeans use as well.
So let's take it really back, and somebody comes into your office and they say they think they're starting menopause or perimenopause. Is it important now to start with the bioidentical hormones? And what does that process look like? Or do you still start with regular hormones, or are we shouldn't worry about that anymore?
You can really start with either, right? It's one size doesn't fit all. So some people want to go the traditional route. There's cost involved with traditional versus bioidentical. There's personal preference involved. There's historical, my friend X did Y, and this is what I want to do as well. So there's a lot of personalization as far as and there's no right answer for everybody. So really talk to your doctor to find out really what's right for you.
Yeah, and then it like you said, it's personalized in regards to you do blood work, and you basically say like, this is your mapping almost, right?
Yes.
Yeah, absolutely. Absolutely. Also, with the patches, there are a lot of women who make end up with a little bit of an allergic response to those patches. They tend to fall off sometimes. So there's some of that. That might not be good for some people. Oral, certainly increases the risk of blood clot more. So, it's better not to do oral if you can help it. Better to do a patch or a pellet or a cream. I think in the bioidentical world, what we use at Exuberan is we really, it really is personalized. So it's based on your symptoms. It's based on, height, weight, do you have fibrocystic breast disease? Will you be a little bit more sensitive to the estrogen? We try to use the minimum amount that will help you with the symptoms that you have. We look at your activity. How active are you? Because hormones are metabolized differently, and active women very metabolized quicker. So, you might need a different dose, and that just makes sense. When I was going through it, I put the patch on, take away all my hot flushes, but I was like, well, I'll just stick with it. And then after a couple years, I got the red patches. So I took the Activella, and I took an oral, and it was like too much. My breasts were really tender, and I stopped. And I'm not really good at going to the doctor myself, so that was it for me. And I ended up not having hot flushes after that. But it was really hard. I think that when you look for something more personalized, I just think that's better. I agree with what Dr. Lazarus said. I think that's really sort of what the future of medicine should be.
So
I think it's important.
Yeah,
I was gonna say, I think
Andrew,
it's
go ahead.
important to note too, for people that we don't always get it right and perfect exactly the first time. Like there's a little bit of tweaking involved. So there's gonna be, maybe you try something and you have high hopes and you're like, oh, I don't like how this makes me feel. Like that's okay. We're gonna work with you. We're not gonna abandon you. But I think because there is now so much more information about hormone therapy, which I love, that people get so excited for it. And when they don't feel like perfect right away, they get real nervous that, oh no, maybe this wasn't a good idea. But again, very individualized. Everybody responds a little bit different. We can tweak, we can add, we can take away. Sometimes it takes a little bit of time, but like we will get you there. You feel great.
So, Andrea, is there something specific when you're dealing with like libido or like vaginal dryness? Like, is there like, we talked about the pellets. Do the pellets work the same as like a vaginal cream would, or do you do like the cream and the pellets combined?
Excellent question. So for most women, doing systemic therapy alone, so like a pellet, a patch, whatever, for whatever reason, why we were designed this way, I don't know. It just doesn't seem to hit the vaginal tissue or the vulvar tissue as well. So for most people, some people can get away with this, but for most people, you're gonna need something for your vaginal vulvar tissues as well. So again, there's even different options when it comes to this. So creams, there's vaginal inserts or tablets or suppositories. There's even rings that you can put in, leave in for 3 months and change every 3 months. So lots of options for that. Libido is a little bit different. I do think that hormone therapy is a very important part of libido. How is anyone going to want sex at the end of the day when they're not sleeping, they're a sweaty mess, they're irritable, they're anxious? Like, no, no, we're expecting too much. Nobody's going to want sex. So getting somebody just feeling back to normal and, helping with sleep. Again, testosterone is very helpful for libido. And then we also have other medications that we can use. There's not a ton of them. Before 2015, we had like absolutely nothing. So I get excited when there's anything. But there's a pill that you can take by mouth called flibanserin or Addy. That one takes a couple months to kick in. But basically instead of working on the hormone part of things, this works on the neurochemicals in your brain. So increasing like dopamine, norepinephrine, those excitatory neurons. There's an on-demand medication called bremelanotide or Vyleesi. It's like a little auto-injector. So you just into your thigh, your lower abdomen. It takes like about an hour to kick in. The biggest kickback I always get with that is like, well, that's not very spontaneous. I'm like, when's the last time you had truly spontaneous sex? You had no idea it was coming. It just popped out of nowhere. It's like, So you inject, you go out to dinner, and then you're good to go by the time you come home.
Right. Yeah. So it's almost like a little bit of a plan. Have you ever noticed that like some women are just like ho hum about like, or they never had a high libido and then they get on this and then all of a sudden they're like, whoa, what have I been missing out? Or is it usually like, it just gets you, do you know what I'm saying? Does it like get you back to where you started? Or does it ever say, like, does a 55-year-old woman be like, well, hell, I wish I was having sex this good when I was 25? Like, does that ever happen?
It depends on the person. And quite honestly, like if you've never had a high sex drive and you don't care, I don't care either. Like, no,
Right.
not everybody has
Right.
to be walking around as like sex kittens. You do you. If you're happy, I'm happy. So,
Yeah.
to that extent, it can be different for everybody. But sure, I mean, I have some of the, you can get a wide variety in responses from some of these medications. I've heard things from like, I was watching Bridgerton and all of a sudden found myself going upstairs to masturbate, or like my husband tried to initiate sex, and my first thought wasn't, ugh. I was actually like, oh, that's kind of a good idea.
Yeah,
So
Shonda Rhimes must be going through menopause. She's giving the ladies what we want, right?
Yes.
We're like,
She
honestly
is.
though, like all over TikTok, it's called Book Talk, and it's all these like new age romance novels. I was like, that's what like my mom and grandmother bought. Remember, like in the grocery food store with like Fabio on the cover? Like it's always been there. It's just like a new way to present it. So it's like, yeah, like if you're watching, new season starts tomorrow. So it's like perfect. We're doing this today. Call up your docs, get on the bioidentical
Yes.
hormones so you can watch the new season of Virtua.
There's a really great app called Dipsy where you can basically listen to audio porn, because women in general tend to like, they're not like, again, very big generalization, but men are like visual, like, oh, there's no backstory, let's just get to this. Where women are like, what's the story? How did we meet? What's going on? So there's this app, you can listen to it, you can be, doing the dishes, whatever, nobody knows what you're listening to, and that can kind of prime things and get you along.
What's it called again?
Dipsy, Dipsea.
There's that new movie on Amazon Prime, The Idea of You, which is based on a book, and the book's really spicy. And the book was great. I read the book and watched the movie, which is out now. And my coworker was like, I started listening to the audiobook of The Idea of You, and it was so spicy when I was at work. I go, well, who cares? Like, get into it, like that's great. She's like on like sending emails and like, whoa. I think the important question about the bioidentical hormones is like, do you need to stay on these forever? Like, what is the timeline of that?
So with bioidentical hormones, we do follow the guidelines from ACOG, the American College of Obstetrics and Gynecology, where within 7 to 10 years of your last period is the safe time to start menopause, to start bioidentical hormones. After that, it can actually be a little bit dangerous. So the 7 to 10 year mark is where we can start. Now, as far as how long you can go with estradiol, it's about 5 years. At the 5 year mark, we always reevaluate and see safety risks, and if you've developed any issues. Testosterone, though, they say you can continue it till they throw dirt on you. So that's something that's safe for long term. So that there are some safety issues for when you start and how long you stay on for estradiol, but with testosterone, you can stay on it long term.
And then the process of like coming in and being like, okay, I think this is something that I want to do. You can start kind of right away. And then every couple weeks or every month or so, do you like check in with your doctor to see how you're feeling? Or do you have to continuously, I'm assuming you have to continuously keep getting blood work and stuff?
Correct. So the bioidentical hormones, it's a small pellet about the size of a grain of rice that gets implanted just under the skin. It's a painless office procedure, takes about 5 minutes. It starts to work in about 2 to 3 weeks. And we monitor by blood work every 3 to 4 months for women. And we also do men, by the way. So every 5 to 6 months for men. And we do blood work, and that'll determine your next dose as well as your response. And if anything changes, again, being very, very tailorable and personalized to you specifically. But you are monitored regularly.
Yeah, this is why the Exuberan program is so amazing, because it's a program specifically for this. And so you're not just, free balling it, if I'm just, saying so frankly, right? Like you're working with these experts who are just really honed in on your care. Really quick, before we go to the Q&A, talk a little bit about, because you mentioned men. I'm sure there's a lot of women who are married and, maybe their husbands are acting a fool and they're like, this is worse than they've been. Or maybe there's some men that are on that, we should talk about that a little bit, just because I don't think a lot of people realize that like men's testosterone can change and all that jazz.
That's right. Most of my male patients are coming in referrals from their wives going, hey, my sex drive is good. Now it's your turn. Because the men, experience around the age of 30 to 40, their testosterone level starts to drop about 1 to 2% every year. And they start feeling tired and fatigued and brain fog, and they just don't want to, they're apathetic, their libido goes down dramatically. So we found that, that their testosterone level has been low. And by the way, a lot of doctors will do blood work for these men and for these women, and their blood work will come back normal. But in the bioidentical world, it's actually very low. So testosterone levels like under 600 in our world is actually very low and can cause all of these symptoms. So when the women bring their husbands in, within 2-3 weeks, I mean, literally they tell me that their fog just lifts. I mean, it's really crazy. And if they're having a sex life like they did in their 30s and 40s, I can't promise teens and 20s, but 30s and 40s, and most people are really happy with that. So yeah, I have husbands and wives all the time.
This is a great question. Can you get bioidenticals from an OBGYN, or do you have to go to a specific specialist?
Well, Exuberan by Virtua is Virtua's bioidentical, but there are other, facilities that do it as well. But traditional OBGYNs don't do bioidenticals only because they do their GYN and OB work.
Right, which makes sense. Another great question. What if you don't know when you stop menstruation because of an IUD? Or I
That's
guess the pill too, right?
Yeah, that's okay. In fact, it's really nice when you want to use bioidenticals in perimenopause and you have a progesterone ID. That is fantastic because
Our favorite patient.
yes, we just give you estrogen and your uterus is protected with the progesterone. Sometimes I'll put one in our Exuberan patients, and that works wonderfully. I mean, you don't really need to know when you are menopausal, underneath it all. I would say I usually tell my patients keep your progesterone IUD in until it's expired, until it's done, until the life of it. And you can just take that estrogen or estrogen and testosterone alone, with the protection, because the progesterone is mostly for protection of the uterine lining. So that makes things a lot easier, especially treating women in perimenopause. Usually by the time you get to, 56, 57, you should be done. And menopausal, I would say 99.9% of all women are at that age. You can have the IUD pulled at that point, but there's no real hurry to do that. It doesn't matter. I would keep it in for the life of the progesterone IUD and take advantage of it because it's an excellent product to use along with hormone replacement therapy.
Wow, okay, good to know. Is there a certain age that you should be at to start the hormone replacement therapy, or is everybody different?
I think everybody's different. Because you can have people that go through premature menopause that are, under the age of 40. And for them, like, we're not talking just symptom management. We're talking about life-saving treatment in that group because you're at a higher risk for osteoporosis and cardiac issues. So, it wouldn't be fair to say like, oh, we should just start at age 51 or whatever. It really depends on the individual, where your symptoms are. So again, widely variable, though. I mean, I would say most women are starting somewhere in their mid to late 40s.
Okay, that makes sense. And so somebody said, oh, Exuberan and Virtua is where I went. The consult with the provider was covered by insurance. So people were asking, are bioidenticals covered by insurance? And what does that process look like?
So the initial consult and the follow-up visit to follow up the pellet is covered by insurance. And that's the one benefit of coming to Virtua for that insurance purpose. The pellets themselves are not covered by insurance, but if you have an HSA or some reimbursable plan, you can submit those and get reimbursed for the pellets. But unfortunately, because they're compounded, they're not covered by insurance.
Right.
And there are bioidentical options that are covered by insurance too. Again, like if, outside of pellets, like there's like, we mentioned before, like there are patches and gels and things like that, or like progesterone you can take by mouth. So it's all about whatever works for the individual patient, but there are some things you can get covered by insurance.
What are the side effects from the bioidentical hormone? Somebody specifically asked, did side effects of vaginal inserts? Is there side effects? We talk a little bit about that.
Yeah, so the vaginal hormones in general tend to be some of the lower side effect medications because again, vaginal hormones, it's acting more local. It's not as much treating the rest of your symptoms over your whole body. So probably the most common side effect is an increase in vaginal discharge, but that's kind of a good thing. We're trying to, lubricate things more. I have had some patients develop breast tenderness, and that seems to be especially more when they first start it because their vaginal tissues are so thin that they're absorbing more of this medication. They can start to get a little bit of like systemic side effects, but once that skin kind of thickens up, that tends to go away, or we can just use less of it. I will say there are some people whose skin is so sensitive that we go in there and we try to just add in a nice vaginal estrogen cream, which should be like soothing and happy. And they're like, holy crap, I am on fire. This does not feel good. For those people, I definitely want to see you, because sometimes their tissue is just so sensitive that we have to start with like something compounded where the base has less additives and things like that. That's more soothing to the skin. But in general, people tend to tolerate vaginal hormones really well.
Here's another question. After breast cancer, is hormone therapy a no-no?
Yeah, estrogen would be a no-no. Once you have breast cancer, estrogen would not be, but testosterone is certainly an option.
Yeah. It is crazy because somebody commented how Viagra is covered by insurance, but bioidentical hormones isn't. It's the patriarchy, people. The patriarchy.
Yeah, and you know what? And you should tell your insurance company. So if every woman
Yes.
complains to her insurance company because you're their client, I think it's all gotten confused. But we are, when you have this insurance that is either purchased by you or by your workplace for you, you're the client. So just like back in the 90s, early 90s, they didn't cover the thin prep paps in the beginning. They didn't. And I remember we all called in. We would tell people, call in. And they changed. Now they cover it. Can you imagine pap smears, the best pap smears not being covered? This should be covered. And we should all make sure that we speak up to our insurance companies and say, we expect this. This is something that we want done.
Yeah, I don't think people, especially women, realize they have a lot of power, right? And there's billions of women, and it's important to speak up and say, like, I want to feel better. And if every woman bombarded their insurance company being like, this is insane, I think we can get some stuff done. This is a really good question. Can you take bioidenticals after 10 years of being in menopause if you're still experiencing menopausal symptoms?
So after 10 years, it's really not indicated for estradiol and progesterone, but you can do testosterone and at any point after menopause. That is safe after that.
Okay, so if they could so you could be experiencing stuff, maybe say 3, 4, 5 years, and just say, I'm miserable, go to see your doctor and then start on it. It's not like you have to start the bioidenticals immediately when you start menopause, right?
Right.
Yeah. The women sorry. Go ahead.
No, I was just going to say, I think some of this is changing too, because the Menopause Society recently came out with a statement that we don't really have to stick to this, 5 years and then you're done type of thing as much. And there's kind of a difference to, have you been on hormone therapy this whole time and now we're continuing versus you haven't been on hormone therapy at all and now you want to start. So there's a lot of nuance to this stuff, which is very confusing for everyone involved.
Yeah, well, what it is when if you start the hormone replacement therapy, no matter what it is, if you start the estrogen, within 7 to 10 years of menopause, of not having your period, you get less atherosclerotic growth. With estrogen on the blood vessels causes vasodilatation. It's good for you. That's why women live longer than men. Because estrogen is very cardioprotective. But if you go 10 years with no estrogen, you build atherosclerotic plaques, and estrogen destabilizes them. And that's the problem, is that if you add estrogen to atherosclerotic plaques, you get increased risk of blood clot, stroke, that sort of thing. And that's why we don't give it way laid out. When you've had a chance to build that kind of plaque. So that's the reason for it.
Wow, that's so interesting. And because you spoke about blood clots and somebody asked, can you use these bioidenticals even if you were high risk for blood clots, et cetera? She said high factor Van Leiden. I don't know what that is, but
Factor V Leiden, right? So that's an increased risk of blood clot, and you really can't use estradiol of any form when you have factor V Leiden. You can use topical estradiol vaginal, but nothing systemic, unfortunately.
Yeah. And that brings up a good point. Breast cancer too. Vaginal is safe for everything. Don't read the packet for it. Just, I always tell people, throw it away, take it out and throw away don't read all the warnings, because vaginal estrogen doesn't get absorbed enough to have any problems in people who've had blood clots, heart attacks. You can even use it after uterine cancer, breast cancer. Absolutely. After 10 years, it doesn't matter. You can always use vaginal estrogen. The packaging says that because that's what the drug companies put on there. They do that for, I guess, legal reasons, and there's no way that's ever coming off. But it's unfortunate, very unfortunate, because we'll prescribe it, and a lot of women will read the packaging and get so scared they won't do it.
And vaginal estrogen is one of the safest. It's literally such a ridiculously safe drug that's gotten such a bad rap. I mean, in Europe and some places it's over the counter. But that specifically is one drug that I always say, like, till death do you part. Like, you go through menopause or premenopause, stick with it, because again, it's super, super safe. And once you stop it, all those nice changes that you've gotten, like the lubrication and protection from UTIs, that all starts to reverse. So especially for vaginal estrogen, it's not just a sex thing. Sex is super important, but if I've got a 90-year-old woman in the nursing home that gets UTIs all the time, I'm like, get girlfriend some vaginal estrogen because she needs it. It's going to save her life.
Yeah, people, you can't play with, especially when you get a little bit older, with your the UTIs, because they could wreak havoc on people. I don't think people realize that. It's like, woof.
Yeah.
Somebody asked about migraines and bioidentical. Is that a risk factor? Can you be on it?
So that's an interesting question, actually, because there's different kinds of migraines, right? So some people have estrogen sensitive migraines, and they can worsen with bioidentical when you give estradiol. But most women find that their migraines improve with the bioidentical because of the hormone fluxes and the hormone estradiol drops. So it's less of a risk with the increase, and most people wind up feeling better with their migraines on estradiol.
I get migraines during my period. It's like crazy. It's like clockwork. And I'm like, what the hell? It's so annoying. So, okay, another person asked regards to, if you go to a doctor that isn't sure about bioidentical hormones, should they do? I'm thinking, like, fine, you can always get a second, third, fourth opinion. I think it's important.
Absolutely.
Yeah.
You come on,
All wonderful women. Yeah.
we love to see you at Exuberan at Virtua. We really make it very nice. We do we have a great team, and it's a definitely don't be put off. Don't be brushed aside. I can't tell you how many times I know Dr. Les will say, should we sit with patients, and they'll say, I feel like I wasn't heard. I've been talking about this with my gynecologist for years, and I feel like I haven't been heard. And that's such a shame. It's such a shame. I do think sometimes too that when you're, as an OBGYN, you're busy, you're running around, you're doing obstetrics too, there's not a lot of time. There's 15 minutes to see the patient. At Exuberan, we have very long appointments. I know so does Andrea Martin have we really try to take our time, and it's just built differently. It's built as a different service at Virtua, so that that we will hear you and we'll work with you.
Yeah, anytime a doctor tells you to suck it up, find a new doctor. That's not the right doctor for you.
Yes. So somebody asked about Factor Van Leiden, and I say that right? Is that because there anything they can use, or are they shit out of luck?
Well, I don't think they're shit out of luck. I mean, we know that transdermal options, like a patch or that type of thing. And I can't speak to pellets. I don't do pellets, so correct me if I'm wrong, but there is no increase in your baseline risk of blood clot if you're using a transdermal approach. So you're already at an increased risk of blood clot, but as long as you're not taking it by mouth, it's not increasing your overall risk. And I don't see any reason why somebody couldn't use like progesterone, but you were going to say something.
And testosterone as well. Testosterone. You can always use vaginal estrogen for sure. Vaginal estrogen with no increased risk at all, and testosterone.
So 3 really good questions. We'll try to, because we only have 10 minutes left. Time flies when you're having fun and learning. Is hormonal treatment different for those with an autoimmune disease?
So that's actually a great question as well, because one of the things that we found with hormones of any kind, traditional or bioidentical, because of the joint pains that happen with the hormone drops, that joint pains with autoimmune disease, the inflammation tends to go down. It's not going to fix everything really, but it can absolutely be part of your treatment plan if you are menopausal. The joint pains can improve in autoimmune disorders.
Okay. All right. So so many questions are coming in about hair loss and weight gain. I mean, we probably could do a whole hour on that, but we saved it till the end.
So, one of the things that the worst thing about menopause is that mid-abdomen weight gain. And it's the most frustrating thing because no matter how much you exercise, how much you eat right, you'll never lose that middle, weight gain. So one of the things with the bioidenticals, at least I can tell you, is that it will not cause weight loss, but what it can do is decrease that bloating sensation in your midsection, and it makes your exercise more effective. You build more skeletal muscle mass. So whatever exercise you do, you find yourself toning. I used to do weights all the time before I did the bioidenticals, and now I'm finding, toning, I can make a muscle and, and you can actually see the definition. So those kinds of things. But the weight gain is a very tough thing with menopause. It's a very tough thing to get over, but we can at least stabilize it.
Yeah, and I think the key to everything is, when you feel better with the hormone, you're not sweating all the time, you can exercise better. I think certainly eating smart, eating healthy, making good choices, it all feeds into each other. When you feel good, when exercise helps you feel good here, it helps your body feel good. It makes your blood flow everywhere. It makes you want to have sex too. If you take, you're more active, you tend to have a better libido, you eat healthier, you feel better. And I think the hormones play also a role in that, giving you energy, making you less sweaty so you can go get a good sweat, that you deserve, to get. I think it just all plays into each other. And I think you really have to pay attention to all three, like a tripod. You really pay attention to all of it. And that's the win.
Because I could see some women being like, I'm already sweating without even doing anything. Now you want me to
who wants to
sweat
work
more?
out when they're a sweating mess? Nobody,
Right.
that's how you feel afterward, not before.
What about hair loss?
So hair loss certainly happens as we all age. In some women, it's you can have genetic hair loss as you get older, sort of like male pattern baldness can happen to some women genetically. And then certainly as we age, as you become elderly, there's definitely hair loss. The hormone, replacement therapy isn't really going to help too much with the hair. I would recommend seeing a dermatologist. I think that they really, have some new things that they can help with hair loss. I can tell you though that the testosterone that we use, certainly we don't give it in huge amounts that you would get hair loss. But I think if someone is having real hair loss or male pattern baldness, which can happen to some women, I think it's really best to see a dermatologist.
I think it's interesting too, especially looking at like the menopause transition. You've got kind of this shift in your ratios of hormones. So your estrogen levels drop. So you kind of have, it's not like your testosterone levels are actually increasing your androgen levels, but the ratio is. So you've got a little bit more androgens on you. And what that can kind of do is the hair follicles can become like smaller and thinner. So, and it's interesting, like we know that estrogen is in some ways protective of hair. And like when women are pregnant, they've got like this beautiful, long, flowing, thick hair, but we haven't been able to nail down, like, just because we give you estrogen doesn't mean necessarily that it's going to do anything for your hair, which is very frustrating. So I'm hoping somebody somewhere will figure that out one day.
Yeah. Yay, science. But you brought up exercise really quick before we go. I think a lot of women have been told that like weights equal bulkiness, but I think it's important to reiterate that like weightlifting is so important. And I think it's something that we've really honed in on maybe the last like 5 to 10 years. But I think since we're talking about that, I think women thought it has to be like cardio, but like lifting weight and strength training is so important.
Osteoporosis is a killer of women. There's a 10% mortality rate, 10% mortality rate with osteoporosis, not in your 50s, not in your 60s, but in your 80s and your 90s. And, we're talking about how many of us make it to our 80s. Well, you don't want to be in your 80s in a nursing home. That's not the point of making it to your 80s. The point of making it to your 80s is that you can be, having fun, enjoying your grandchildren, your great grandchildren, maybe,
playing pickleball, playing pickleball,
or regular tennis, whatever it is. But absolutely, what happens is you end up having a fracture and then needing surgery in your 80s, and that's what killed. That's the problem that's happened to my mother actually recently, and it's such a shame. So important to do weight bearing exercise, to do, even if you've, it doesn't have to be heavy weights. That it just has to be consistent. Also practicing balance and stability is also important. Core work is very important because we use our core with everything that we do. And as we get older, we're more at fall risk and so important to do all that, and salmon, if you love salmon, it's good for your bones and your heart, your brain. So salmon 3 or 4 times a week, really, really good to get your calcium and vitamin D, and lift weights is good too.
Yeah, there's this woman listener, shout out to Rita, who's 74 and she does like a 4-minute plank. I'm like, I can't even do a 4-minute plank, Rita. Crazy. All right. So before we wrap up, is there one piece of advice that each of you would like to leave the amazing attendees today?
My advice to everyone today is really take care of the whole you, all of you, from stem to stern. Take care of it, exercise, eat right. If there's a problem, if there's a symptom, go see your doctor and don't take no for an answer. If you're not getting the answers that you want, find someone who'll help you, because someone will be able to help you, and you really shouldn't suffer alone.
Yeah, absolutely. I'd say, when Virtua says we're here for good, we're not kidding. We are here for you for good. And, come see us at Exuberan, or, come see Andrea Martin at Sexual Wellness. We have so many offices that are set up with providers who are there for you to spend time with you and to really help you through all of the transitions of life. I think that's so important, to really partner with your patient, and that we all need to learn from each other and partner with each other. That's how we all win. That's the win for everybody.
Andrea?
And I would say, of course, taking it back to sexual health, that sex should never hurt, I guess, unless you want it to. But there's no reason. There's different kinds of hurt during sex, but there's no reason, like, if you want your sex life to take more of a front seat in your life, there's no age limit to this. I have women coming to me in their 90s, women, all different ages. Like, if sex is important,
wait, there are women in their 90s still having sex?
Absolutely.
Yeah, absolutely.
I
love it for them.
The new episode of Bridgerton. This is season.
Yes.
The geriatric years.
Yeah. Sorry, Andrea, cut you off. Go ahead, finish.
No, I think that's important, that we should have geriatric Bridgerton. I think that was a very important topic you brought up. Let's do this.
Let's do it. What a great note to end on. I love this so much. Remember that you can be filled with vitality at all stages of life, which is what we really wanted you to realize today. And recording of this session is going to be emailed to you sometime next week. If you'd like to schedule a consultation for bioidentical hormone replacement therapy at Exuberan by Virtua, just call 856-325-5601 to connect with a specialist from Virtua's Sexual Wellness and Pelvic Health, 856-247-7435, or to schedule one of our other women specialists, just call 833-VH-WOMEN or visit virtua.org/women. That's a great place to start. I mean, obviously you're going to get all this in your email, but virtua.org/women is easy. Unless you like to pick up the phone, phones still work. So you could do that too. Thank you again so much. The fact that you're here and learning, you want to better yourself, like, take pride in that, because I think there's a lot of women that wouldn't have jumped on. And so that means you want to feel better. So we hope you feel better. And that's why Virtua is here. Thank you so much, Dr. Kramer, Dr. Lazarus, and our sexual wellness APN, Andrea Martin, for another incredible Real Talk session. Thank you so much. Have a great rest of your week.